Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Since then, okay, sorry for that. Since then, I have been working here in Portland, mostly in my own practice. I'm not sure if I'm sharing my screen, by the way. Am I? It says desktop keynote. Here it is. Share. Okay. There it is. I thought we'd start with a joke since it's so early in the morning. This was in the bathroom of a restaurant in, I can't remember where. Okay, so let's start. So this is from an article from Rhonda Jacob. It talks about dentures, but I thought it was, when it comes to occlusion, I always find it fascinating. Deduction, it's one of the ways we practice dentistry. We collect information from available data. A second way we do it is with induction, where we have an idea and then develop some form of research in order to come up again with conclusions and so forth. And perhaps the most common in the subject of occlusion, it's seduction, in where we have our own philosophies that are shaped from dental school and then residencies, if we go to residencies and commercial institutes and things like that. And so it's a little bit of a difficult topic because clearly this is not like giving a lecture on, I don't know, complications with implants where you just basically, can show a lot of data. This is more about my own observation through years, I guess, and my own dogmas. So I hope it's helpful in that sense. And by the time this lecture was prepared, and this is a very short lecture version of a very long lecture, you can see my point. When you look at I collected the articles related to occlusion that were published that year, and you can see there were a lot of case series, there was expert opinion, there are reviews of literature, and when it comes to real studies, there was just one retrospective study, one epidemiological study, and one animal study and nothing else. So data certainly lacks. So, but this is also another article published in the Journal of Prosthodontics, International Journal of Prosthodontics years ago, and it talks about, a study to look into whether the use of parachutes is really acceptable to be used in order to avoid death. And, they found that there were no well-designed studies that prove effectiveness of the parachute use. In fact, the only data available was emotional, anecdotal from users and manufacturers, and therefore they couldn't recommend the use of parachutes. And it was in a way a bit of a joke, but the point of this is well taken in that if we don't have the scientific data, as we actually don't have enough scientific data on occlusion, we do have to rely on our own experiences and the experiences of others. So again, this is, in a way, an introduction to apologize for the lack of science in this lecture. So I'll start with occlusal schools, and this is a cartoon from an Argentinian author named Kino. And I think it's very, very, very true on occlusion. And, whether it is a nathological principle, and there are obviously few branches there, or whether it is something more related to Jankelson principles and neuromuscular principles and things like that. I think the problem is when we as practitioners get stuck into just one school. I think it's very important that we open our minds a little bit and realize that there are more ways that sometimes there are different ways that fit patients, and also that sometimes we have to get out of our box in order to solve a patient's problem. I came up with this some time ago, and I think it also applies to the subject of occlusion. Specifically, I think it was Lucia in 1979 who said that the adaptability of patients is what allows us to do the things that we do, and that and it's also is what makes us defend our philosophies, because with our success, and when we are not successful with what we do, we will term patients as neurotic, and I think that is true. And if you look at this, what I try to say in here is that if you look at the colors, red is the spectrum of unacceptable care to be in one extreme, and then that green area in the center is like at the absolutely best dentistry you can provide. And that there are different patients. There is what I call the cowboy patient, which is or who is the patient that you bring to the chair, and it doesn't matter what you do, especially when it comes to dentures and things like that. He or she will go, yeah, fantastic, and perhaps the care you provided isn't the best. Most patients are somewhere in between. They, anything that is about standard of care and above, patients are happy with, and sometimes they don't really recognize the difference between great dentistry and ordinary dentistry. But then there is the neurotic patient, if we want to call it that way, which is the patient that really is sensitive to what we do. And so the important part of this is that their adaptability is different, and that's what's going to determine whether you have to get out of that box that we are talking about or not. So all this is just an introduction, and let me finish the introduction with why my own dogma is, so that you know where I come from. The first one is that occlusion shouldn't be driven by a philosophy, but it should be driven by the clinical presentation of the patient. And I will expand on that quite a bit, but the point is we really have to fit whatever works for the patient. That's basically it. The second one, and also I will expand on this, is that occlusion is dynamic, it's never static. I will talk about articulators being completely static, centric relation being static, and when we say tap, 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 that is pretty much static. And when we tell patient go left, go right, it's a little movement, but really at the end, what we look is at the end of, call it canine guidance, and that again is static. And that instead, we should be looking to these patients from all the functions they perform, which are very complex. This is almost at the end of the lecture, but occlusion is greatly affected by both mechanoreception and proprioception, and this is something that I think has been grossly ignored in dentistry. Occlusion is greatly affected by the airway. This is something that now it's being recognized, but in general, it was ignored for years, and especially on the Class 2, Division 1, and Division 2 patients. The idea that evaluating speech, swallowing, and chewing, it's going to be the best way to understand your patient's occlusion. Again, evaluating patients by putting them in centric relation or by having them tap in or whatever is it that we do isn't really gonna be enough. You have to have them perform the things that they do more often. And this is really important, that not all TMJs are healthy. And my background is in maxillofacial prosthetics, and I see a lot of temporomandibular disorder. And when the TMJs are not healthy, you can't treat that patient the same way. The best example of this was precisely with centric relation. How can you establish centric relation on a patient that has temporomandibular disorder? If you think about it, you really have to adapt to whatever the patient has in that joint, and sometimes that means that the patient cannot be in centric relation. And in the same token, that not every patient is a class 1. When you look at all these philosophies of occlusion, they are mostly treating class 1 patients. But when time comes and you have to do any form of full mouth rehabilitation, and with that I mean not just a bunch of crowns, but potentially a denture, which by concept is a full mouth rehabilitation. And you have a severely skeletal class 2 or class 3, and suddenly all the rules that you have been taught cannot be applied because the horizontal relationships between the maxilla and the mandible do not allow that. And that when patients that have joint disease with symptoms that are chronic and are not going to progress, the best occlusal scheme is not the one that you feel the philosophy is best, but it's the one where the patient has no symptoms. And that may mean anything, and it can look or be or seem very crazy in a dental crowd, but at the same time, it's what's best for the patient. So let's start. And basically, what's going to happen is I'm going to just go. I call it random tips because it really is going to go a little all over the place. It's just there's no much organization in here, so bear with me. So the first thing, and it's kind of what's going to be, then we can expand from here, is that it's a joke. Your child won't develop fever if he is in a centric relation. And that's the point with this is that centric relation at times is not necessarily the best position. Sometimes it is. And then even when it is, it's not a pinpoint position, but that it actually it has some form of a field of function. It's not just one small point. So that was written by Sears years ago. I think it's still true today. You can read it. So when we talk about centric relation, the first question that I have is it repeatable? Can you really repeat centric relation? Because that's basically the biggest advantage of centric relation when compared to any other form of starting point on occlusion, is that you can repeat it. And yes, I think that if you use the modern concept of centric relation, most superior, anterior, medial, and so forth, where is a relation of bone to bone on a healthy joint with a healthy disc in between, yes, it's very much repeatable, and you can put the patient there anywhere. However, if you use a concept of a more retruded centric relation, then you can get difference of 2 millimeters in the same patient the same day. And furthermore, even when you can repeat it, the true question then is, does the patient function there? And that is the second question. And again, it depends. Sometimes, yes, the patient functions in centric relation. Charlie Gibbs, who was one of my teachers, did a lot of research on this. And things that we do a lot. For example, swallowing does not happen in centric relation. Swallowing happens near maximum intercuspation. And the cumulative forces of swallowing are greater than the cumulative forces of chewing. So one could argue that where the teeth are during swallowing can be just as important as where the teeth are when you're chewing or when you're biting down. And when you're chewing, depending on again the health of your joint, you may chew in centric relation, or you may chew anterior to centric relation, or both. And that also depends on the skeletal relationship that you have. If you have a class 3 or a class 1 relationship, and you have a healthy joint, then you're likely to function near centric relation. But if you are a class 2 division 1 patient, you probably don't really function in centric relation. You function much more anterior than that. And something else that Charlie Gibbs found was that there is no such thing as a hinge axis during chewing. So again, it brings the question of whether it's is it functional? Yes, it is, but it's not for absolutely everybody. So we shouldn't be stuck with that. And then it's stable, and one of the best studies that look at this is the study by Salenza in 1973, and he was an pathology guy. He, centric relation was the sun for him, and he got 32 cases that he completed, full mouth rehabilitations in centric relation, and without any form of range, but just there in centric relation. And then what he did is he followed up these cases for a year or two, and all cases without exception end up developing a slide. And the smallest slides was 0.3 millimeters. And the interesting thing is that none of these patients develop any wear facets. So, meaning with that really centric relation isn't enough. You have to have a little bit more. And especially again on patients that have either joints or joint problems or skeletal conditions that make them function in different places. And then is centric relation orthopedic? And it can be orthopedic, of course, but not always. Again, in my experience with temporal disorders, most patients that have issues in the joint cannot really function in centric relation. And so I think it's orthopedic in the sense that it can maintain stability in a joint that is healthy, and sometimes in a joint that isn't that healthy either. But it's not the panacea of stability and the only position that a joint can function. And I guess, as I said in my introduction, in my own dogma, is that to me the best occlusion is the occlusion the patient likes. Is it acceptable for patients? I cannot explain to you how many thousands of patients. Well, I mean, I'm exaggerating, but a lot of patients I've seen who come restored in a way that just they cannot tolerate, and minimal adjustment just does it. So when is centric relation not necessarily the best option, or when are you potentially going to find that? And the first one for sure is temporomandibular disorder, especially retrodiscal issues, inflammation on the retrodiscal area. It's a really common one. A second one would be a anterior displacement with or without reduction, in where there's capsulitis and the condyle move forward, captures the disc a little better, and the patient feels better in that position. If that is not restored surgically for whatever reason, patients are going to tend to prefer to be a little more forward. And in fact, I will show you later, the brain will actually make that mandible move forward to avoid pain. Class 2 patients, again, I'll show a lot on this, and it correlates with airway issues. So, you know, in the class 2 patient, the base of the tongue is pretty much collapsing the airway. And, you know, I think Ricketts in the orthodontic literature was the first one to describe this, that the patients function much more forward because, you know, they have to breathe. And so when they're chewing and the breathing is happening, if they were chewing in the back, the airway will be collapsed. So you'll see on the class 2 patient that will be common. Anybody who's done a complete denture in their life knows that you know, you can put your complete denture patient in Centric Relation, and some of them will be fine and will go every time there. But there are others that, for whatever reason, do not. And again, I'll show you some cases in here where, you know, patients can function more forward. Sometimes they slide to the right. And this is independent. What's interesting is that this is independent of occlusal contact. So it isn't an interference that's causing this. It's actually the lack of mechanoreception and proprioception. And the last one is just habit. That's just, you know, the patient doesn't function. There are people chew in different ways. We have different tics, I guess, and not everybody is going to function in the same spot. So I think this will be, and again, these are all exceptions. Clearly, most people can function around CR, but it's important to recognize that some of them do not, and we should be able to get out of that box. This is an old case, but it's basically a complete denture with a very old-fashioned hybrid. You can see all those, the usual 5 implants that used to be placed years back, and there are Brandon implants, as you can see, and they're very close to each other, as they should not be, but that's how we used to do things. And that was my favorite way to take a record. You know, you have a very stable record in the mandible, and then you have a maxilla. And I have a Gothic arch in there, but the thing about it is, if I use the Gothic arch in the classic way, I would be putting this patient in a retruded position, which most denture patients will not be able to function. But, you know, I like to do this system just simply to find the position the patient prefers, and then just simply use the Gothic arch against the little plastic device that one puts in the other portion of the plate in the maxilla, just to fix the record. And so it's a good example of, you know, using the knowledge of that we all learn in residencies and things like that, where we, you know, get to use a basic principle of centric relation, but deviated it a little bit in order to make something more practical. Let me show you a couple of videos of edentulous patients just to make that point. This guy, the first one, I'm you know, trying the dentures, and I've been moving this teeth forever because he closes, and after he closes, to move left. And you know, if I had, the point with that is that if I have a very a one position occlusion, when he moves to the left, he will have an interference in the denture, you know, either will have instability or mechanical complications. So I basically got rid of every single cost that, and when you look at the denture, it will probably look too flat, but I have to be sure that he can do that, because he will do it with the wax frames, he will do it with his existing dentures, he will do it with the new dentures. So just take a look, it's just a few seconds.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now open back and close it with your back teeth. Perfect. And now it slides a little bit.
So that little slide. So it's something small. And so his maximum intercuspation really becomes that little lateral, almost canine guidance there. And you know, you can argue that that's wrong. But you know, once again, I'm going to go by he's happy and comfortable with that, and so that's where I'm going to leave him. A more common example is patients that come already wearing a denture that is collapsed. They ground the heck out of that denture, and you're trying to get them to learn something new because they posture the jaw so forward because the denture is so damaged, and so that's a different scenario. But what's interesting is even after you go through a period of training and temporary dentures and so forth, the habit of moving the jaw forward will still be there. So check this out.
All right, just bite down.
So that's the old denture, what you're seeing right now. And so that's why, that's the very first appointment. I'm just trying to see where he truly, where his centric relation is his old denture is
Right
collapsed.
there.
So it's somewhere in there. You can see it's edge to edge, but then he moved forward because clearly the denture is unstable. And that got to go back to Salenza, and something that, you should consider always, that it's not really the joint that dictates your occlusion and where the patient bites. It's proprioception. It's whatever the brain can find the most amount of teeth that meet together and create some forms of stability in maximum intersulpation. And the reason is simple: you will need to eat. So look at what I did on this patient. I began building on acrylic of a very different color on purpose to train this patient, and it took a few months, really several follow-ups, and ultimately I got him into some form of stable scenario, and they make a new denture for him, and here's the new denture, and you'll see that he's still, now clearly there's more stability, but the anterior posterior movement never ends.
Bite down, very good. Bite down, very good. Now let's see how well can you control yourself. Let's try to bite in the back where where you're supposed to bite down. Open it and just quickly close. Great, much better.
You can see that there's really no control in there, and so he bit in a couple different places, and I think that it's important that your denture accommodates for that. This is the opposite example. In the left side, this is the patient that comes with the maxillary hybrid. And, in that maxillary hybrid, the patient is happy but says something doesn't feel right. And patient cannot pronounce words. And you deprogram that patient and then have him bite. And then that's what you see on the right side. So what ultimately happened, of course, I'm doing this in a more of a detective type of work. Okay, well, what really happened here, and this basically those maxillary anterior teeth were set way too forward, and so the teeth are reset, and that's it. The patient is happy, and so that brings another issue for me, and that is two things. First, whenever you're doing any form of complete arch rehabilitation, and again, whether that is a plastic teeth in a denture or whether it is crowns or whatever, you have to check your occlusion and your records every appointment, just to be sure that whatever it is that you're using, it's really stable, and that's what the patient likes more. And the tip for this is always do it the very first time. Meaning, let's say it's a denture and you're trying the denture on wax. Do not let that patient close down before you see it. You put the denture in, and that very, very first time the patient bites, when the patient bites, it seems a little more forward, whatever, then your position isn't stable. Because typically, the very first time the patient bites down, the proprioceptive signal from the denture has not been introduced yet. So the patient, let's call it, it's still a virgin in that sense. It's going to go to whatever he is more comfortable. Now, of course, there are situations where patients are going to go to places that you simply mechanically cannot put the teeth in there. But if you really pay attention, you'll see that you won't miss a lot if you do what I'm saying. Just basically look at that very, very first time. And that's with the edentulous patient. But here's with the dentulous patient, and this is the class 2 patient. And what you see there is, you would think that I told the patient to slide to protrusion, but in reality, what I did is I asked her what she did this morning, and she started talking, and I interrupted her. I said, hey, open for a second and close down. And that's where she closes first. So that's, if you do this as an exercise, the very next 10 class 2 division 1 patients you have in the office, do that exercise, and you'll see that 7 out of 10 will do this. And the point to that is, well, not necessarily that you're going to restore them there, although sometimes I'll show you a case where I did, but more that you have to be aware of it so that when you develop your anterior guidance, and then when you put where you put your anterior teeth and so forth, you know that that patient is going to be doing that a lot. So what is the prognosis of, for example, a maxillary hybrid? You know, they break a lot. And if you put the teeth like that, how many times number 8 and number 9 are going to break unless that hybrid is made out of zirconia? Let's see what's happening here. Okay. So this is to explain the phenomenon I'm talking about. So, you know, you see these 2 patients, both of them skeletal class 2s, and you tell me, you know, which profile looks more normal for this lady on the left and which profile looks more normal for this patient on the right. And I mean, it's obvious that the patients look better as a class 1. But it's not just that. It's that if they are not in class 1 when they are in rest position, or when they are eating, or when they are chewing, or when they're swallowing, well, they can't breathe. And so sometimes, especially with treating my temporomandibular disorders, I put patients in flat night guards or appliances, whatever you want to call them, no anterior guidance whatsoever, so that they can, slowly find where they want to function. And what you see is that a lot of these class 2 division 1 patients have that dual occlusion that I'm talking about. And you can see it in there. There's the blue, which is close to centric relation, or maybe eccentric relation. And the red is where the actual patient tends to function more. And so when you're designing your prosthesis, I would argue that you have to create a great deal of freedom and flatness from position A to position B if you want to have stability, both mechanical and biological. And the opposite of that is the pseudo class 3 patient, when you have a situation like this one, and this lady or this girl is getting married and she wants veneers on her maxillary anterior teeth. And, you know, if you're inexperienced enough and you like cosmetic dentistry, you jump on this like crazy, but the reality is that this is where this patient truly functions or wants to function. It's more close to central relation, but the position there is quite unstable. You can see patient was in orthodontics, because you can see missing that premolar there. And I don't know how many people are listening to this, and I don't know how many are orthodontists, but unfortunately, a lot of orthodontists, in my experience, just put teeth where they look pretty, and that's in my hands or in my observation can be a problem. So, you know, if I was to restore this patient and do the veneers, well, because she's truly a class 2, as I showed you in the previous pictures, she's really functioning forward, and she's going well beyond that relationship that you see on the left side, and that's why the teeth are worn out. So you put veneers there, especially to increase the length of the teeth, they're going to break. Now, clearly, most of the time, as I said, we work in centric relation because of the reasons I explained. You know, it's easy to replicate, and you know, a lot of people function near that and so. But sometimes, as I said, you know, you have to function away from that for different reasons. But there are challenges to that as well. The biggest one may be that you can replicate it, because if you restore your patient in any position that's postural, you cannot replicate it. If I woke up this morning sounds like a blues song. But if I woke up this morning and I slept well and I, drank a cup of coffee and I'm relaxed, and you try to put me in position, call it B, and then later in the afternoon I go to the office and it's a mess, and then I come home and I have an argument with my wife or whatever, the position, my mandibular position is going to change because it's strictly dictated by muscle. And muscle, changes according to what's going on. And so it's certainly much more difficult to replicate, which means that the idea of an occlusal scheme that gives you a range is even more important. It's not always stable in time, for the same reasons. And so you have to, if you, this is, I guess, another tip, if you either restore a patient that's away from that, typically if the patient is dentated, you want to give them some form of appliance to maintain the position you created at night. Well, whether you restore the patient in a postural position or not, you definitely need to consider it. So, meaning with that, what I've been showing you, if you are going to do centric relation, which you probably will in most cases, you still have to consider all these offbeat places. And these postural positions, you have to know why they're there, and that actually can help you. They can be muscle memory, that you can treat. It can be lack of proprioception or mechanoreception. Typical example is the patient with no teeth and maybe with implants, which is even more dangerous. And again, can be airways issues, or it can be issues with the joint. Let me show you one case. I show you a few identulous cases. Let me show you a temporomandibular issue, and it's just a couple of photos, but this is a lady that I put on an ERPS appliance and an anterior repositioning appliance. And the reason I did that was she has a lot of capsulitis and retrodiscal inflammation and quite a bit of pain. She went into a flat appliance first. Some of the muscle pain went away, but the capsular pain would not. And I basically moved the mandible forward, and at some point the pain just went completely away. And it's one of those situations, and I've heard this from patients many times. Again, I treat a lot of temporomandibular patients in where they have nightmares where they lose these appliances, and because the appliances is really the difference between pain and no pain. So, you try to, once you have the symptoms controlled, you try to put them back, and when you try to put them back, just pain comes back. So, clearly, for the sake of the patient, it's best to try to put them back, because then you don't have to do anything else. But if the patient cannot tolerate being back and has to be forward, well, then you have to consider orthodontic treatment or some form of, rehabilitation. In this case, though, it was quite easy because it wasn't that bad, as you can see. One of the problems, if you restore a patient forward like this, is that the occlusal plane height can become very high. And as you know, the patient is going to start biting tongue and so forth. But in this case, because the teeth were so lingually inclined, there was no issue with that. The issue, of course, with that number 29 there, which, if I recall correctly, this is years ago, was extracted. I can remember. But basically, here's how the case ended. This patient was a pretty severe class 2 division 1 patient, and you look at her now and it looks like class 1. And if I present this case in my prosthetic board, I will probably fail, but not in the patient's mind. That's the patient right there. And here's the beauty of it, is that she has sleep apnea, and you can see the numbers there. I don't want to get too hard on that, but those numbers, believe it or not, are without appliance. So at some point, she didn't need the appliance anymore. She, the muscles and the proprioception and mechanoreception and so forth, she just became a class 1, and I guarantee it that there was some remodeling of her joints as well. And her numbers improved in the sleep study without an appliance. Now, if we are considering all these issues with centric relation, and the fact that we should consider it more of a range instead of a point, and these postural scenarios is so formed. Well, what do we do with anterior guidance then? And so research with anterior guidance is interesting because we're taught that canine guidance is the way to do everything, and the reality is that science doesn't really show that. Most people, or a lot of people, I should say, function in some form of group function, and it depends on many things. There is no prevalence of TMD between group function and canine guidance, and they are both normal occlusions with canine guidance or with group function. So, here is a diagnostic waxing of a patient of mine, and you can see the cingulum is not really a cingulum. Again, it's just a flat surface. You can call it long centric. There for a class 2 division 1 patient. And then in the canines, the same thing for what I would call wide centric. So that, the point with this is, and this is how I was taught, and that is it canine guidance or is it group function? And the truth is both. You start in centric relation, and the very first half a millimeter or a millimeter or 2 millimeters, depending on the relationship between the maxilla and the mandible, it's in group function, and then the patient goes into canine guidance. And likewise in protrusion, as the patient moves forward, first there is some form of flatness in this kind of a group function, and then the patient goes out of that. And of course, that type of anterior guidance is going to affect the posterior teeth, because the posterior teeth need to be flatter then. Or maybe the patient has Bennett side shift, and so you have to also create more wide centric. And in the left side, you have a case I completed that is pretty much a nathologic case, in the sense that it's a purely centric relation, and you use one point and that's it. And the other one is a class 2 division 1 patient, and it's quite flat. And I don't know, other than the color, I don't know a single patient that will complain that my teeth are too flat on the situation on the right. But that's what staining and grooves and so forth are for. And now that brings the subject of articulators as well, because, if we are creating this flatness, if we are creating this type of group function, do we really need this accuracy? Of course, this is a very old articulator. The person in the left, this was one of the co-residents in my residency. And I don't know, but my take is that articulators are like a salad spinner. Basically, they are something we use because we need them. We need to get the lettuce, semi-dry, but they all suck. They are really not that good. There is so many inaccuracies with articulators, and so the question is, okay, so is it an instrument or is it what drive our rehabilitations? And it's just an instrument, and we have to understand that, and we have to understand the limitations. And the easiest way, if you follow the philosophy that I am describing now, is to use a simple articulator and just set that articulator so that it compensates for any problem. For example, condylar inclination, average 34 to 37. But if you set the condylar inclination somewhere below 30, call it 28 or so, then you're going to be sure that it's going to be the teeth and not the condylar inclination which is going to dictate the angle of protrusion. And so that's all you need to do. You really don't need to have an exact to record exactly the condylar inclination. That's just one example. Same. Likewise, on the side shift or in the Bennett angle, depending on the articulator that you're using, you basically overcompensate it, and so that is always going to be what you do in the mouth what will dictate, and not the joints. And that goes with the dentalist patients as well. You can take a face bow and you can make a wax trim and take a face bow and a CR record, and then arbitrarily have a technician who in today's world of dentistry and at least in the United States, unfortunately, schools are disappearing, have them go and set the position of the anterior teeth and the inclination of the occlusal plane or so forth by using a little ruler that, you know, Hannah gave them, or using the table and measuring the distance from the papilla, from the incisal papilla to the incisal position of the anterior teeth. And, you know, that's okay. But if you actually work a full hour on your wax rim and you really work it, you work the aesthetics, you work the function, and you work everything, I challenge any of you to tell me what is a better face bow than that. I don't think there is a better face bow than that. And also, and that's going to come next, is to the realization that, again, we don't use a static relationship, but we want to use function. So, for example, this patient is a flute player for the Oregon Orchestra, or used to be. And so, watch this.
Okay, that was done. Trying to play the flute.
So as you can see, you know, if he's going to be a flute player, and that's what he does, from the moment of the wax rim, I'm already making sure that that's what's accomplished. Because, you know, if you know music, you know that these people need to have teeth exactly where they need it in order for the lip to make the right sounds and so forth. So that's just one example. This is research by Gibbs to talk a little bit what I was saying. People chew differently depending on the presentation that they have, and that their anterior guidance is completely different. So we have to take that into consideration. So we have to really observe. This patient came with temporomandibular issues, specifically muscle trismus, and nobody could diagnose what it was. And if you just paid a little bit of attention, just try to hear this. I'll raise the volume here and just hear it.
Yeah.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
You hear that, and do you see that? So that patient is clicking the mandibular anterior teeth to the maxillary teeth often and very hard. And that was basically the source of the muscle trismus. So I think observing sometimes can be very helpful. And these are pictures of patients of mine chewing, you know, when we're doing try-ins and things like that. And look at that. What articulator will give you that? Or would you ever tell the patient to go that far? But that's how this patient chews. So if you would have made those maxillary anterior teeth any longer, you'll probably have a mechanical complication or instability of the denture. Or, and sometimes it's not as much how far they move, but look at the tension on the muscles around this lady's mouth. And, you know, you can use it, of course, you can use speaking to find vertical dimension and find the aesthetic plane and so forth. That's nothing new. I didn't invent that. You know, that's come from Pound in the 70s or 60s. I can't remember now. But here's a good example of this lady. I'm doing a maxillary prosthesis with implants for her, and she doesn't show much the teeth. She wants to show them more, but look at it.
Give me a smile first. Good. Now say 55.
55.
Now count from 60 to 70, but do it fast and natural.
61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
Do it one more time.
60, 61, 62, 63, 64.
So as you can see, the first thing in the first part of the video, I hope you saw how much that mandible moved sidewise when she's talking. But secondly is that those mandibular anterior teeth are super erupted, and you see that they're touching that maxillary denture or the wax rim or so forth. So of course, I have to take those teeth down as much as possible in order to be able to make that longer. So that's just basically a very nice form of diagnosis because it's functional. And you can do that not just for the vertical position of the anterior teeth as I just showed, but also the horizontal. This lady, it's a new patient. It's actually, this is last week. And she's unfortunately part of a lawsuit. And it's a lawsuit against the general dentist for placing for crowns that you see there in the front teeth. And you can see by looking at the maxilla and how much bone she shows, she's a pretty severe class 2 division 1, and those patients were farther out, and this dentist decided that he could bring them in to make them look better, except that, of course, again, she's a class 2 division 1, so she's going to move forward, and the veneers or whatever the crowns got in between her function, and she developed severe TMD. And so what you're seeing there is after I have cut the crowns significantly, but watch her functioning.
Go.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
So, those teeth should be longer, but they can't be longer where they are. They needed to be where they used to be, more forward, and then be longer. And then this denture, so that showed me there that I needed to move. I could move, I should say, to make the patient more aesthetic, that wax rim farther forward so the patient can show more, but probably cannot make the teeth any longer. So it's just a form of diagnosis. And of course, if with dentulous patients, you can use things like this. We make a diagnostic waxing and then just basically use composite with Vaseline and just put that on the patient and have the patient function in the same way. With experience, I mean, I don't particularly need this a lot, but it can be very useful for somebody who doesn't have the experience, and the patient can even go home for a day. I know it sounds disgusting, but sometimes it can be helpful. The next point, and I looking at the time and we're kind of running late, so I'm gonna hurry up. And that is that the mouth is an isolated organ. The brain controls mastication. I've shown this video a lot in my career because it tells a story of mechanoreception or lack of mechanoreception. The guy from Japan used to own a sushi place in here, and what you see on top there is a wax rim, teeth on wax, and watch his control of the maxilla and the mandible showing, I guess.
Close. Open. Close. Open. Close. Don't worry about it. Just open and close. Perfect.
So, this is what I made for that patient, and that's what he did to those molars really quickly after. And I don't know how many times he broke this denture or how many dentures I made. I don't know if Dr. Lebrash is here, but he ended up seeing this patient because the patient got upset with me because he broke everything I made. And so, with implant prosthesis in particular, especially full arch prosthesis that are fashionable, one really needs to be careful because patients not only lack the proprioception and mechanoreception, but also because with the implants they are able to produce forces that are not physiological. And I think that's why you see so much mechanical complications. And so being more careful in all these things that we're talking about become even more relevant. And that's the reason why this is a case that I finished closely. Of course, this is expensive, but my philosophy tends to be to try to do something a little stronger. But more important than that, if you look farther back on the posterior area, is that I kept the molars. The idea of just taking all the teeth out is many times needed, of course. But if there is a chance that you can keep molar occlusion in one side, I think by having the proprioception from those molars and by eliminating the cantilever extension, you really save money, time, and headaches. So consider that whenever possible, which unfortunately is not many times. And this is a little girl that came. Just watch her. She's just laying in there waiting for treatment. Just watch her. She has cerebral palsy. But look what she does all day long. So the result of that is this. And so, they send it to me to see what could be done. And my idea was simply to build her vertical dimension by means of her primary teeth in order to protect her first molars and canines that were coming back out from being destroyed. And it's unfortunate that I saw this patient about a month ago. She's now 19. This is a very old case. No, she's not 19, but she's at least 16. And I guess it worked. So I'm happy for that because this was quite of an experiment. But the point, again, is just that our mouth is so heavily connected to our brain. When you look at studies on mechanoreception and you look at the signals that our teeth provide to the brain and how that signal is disrupted just with a root canal, it's amazing. Or with a crown. And also that the signals are the strongest, no surprises, on the distal lingual cusp of the second and first molars, and they are the ones that break the most, and also on the canines. The second is that short soft tissue follow hard tissues. We learned that in implant dentistry, but also soft tissue help mold hard tissues. So, for example, look at this patient. Why are those teeth like that? And when you look at it, this is why. Patient doesn't have a tongue, lost the tongue through cancer, or almost a full closectomy. And if you look at the neutral zone of this patient, that's where the tongue goes. And so the teeth go exactly to that border. In other words, it's not just like, neutral zone, again, it's not a new concept. It's a concept, it's a concept from England, and it's like from the 30s or something. But and we use it, to put the teeth in the right spot. But in likewise, when teeth are when the patient is dentaless, I think the dynamics and the forces that the tongue and all these things give the teeth also keep them in place. And another example, one would look at that denture on the left and say, my God, why do you make that denture like that? And it's because, there are abnormalities on this patient after a mandibulectomy without a reconstruction. And if I don't make that denture like that, it just won't stay. So sometimes the position of our teeth need to be dictated by our soft tissues as well. We're getting to the end. Look at this case. This is how I started, temporomandibular disorder case. And I put this patient, and I use this often, put these patients in a flat appliance. I think I mentioned that. And I just see them every week. And I see how, I adjust these appliances. They're even. And the patient comes the next week, and they're only hitting on one side. The jaw is rotating. And you keep doing that after they're stable. It takes about 6 months. And it can be as severe as that. And when you look at that, if an orthodontist looks at that, we'll say, oh, you intruded something or whatever. But if you take the models of this patient and you articulate it by hand, they actually would articulate like that. So the issue here is that the mandible actually rotated, and you have to find ways to restore that patient there, well, at least in my hands, because that's where the patient have no pain. So once again, what is the best occlusion for me is the one the patient likes and have no symptoms. This is an Italian set. You may be the head of the family, but I'm the neck. That's what the wife tells the man. And it's just to say that we so far have completely ignored the neck as part of occlusion. And I don't know anybody who have learned in school about this. I learned it from a Chilean physical therapist called Mariano Rocavado. And you see him in there. And you can read some of these things. It's very interesting. Scoliotic patients that have lateral malocclusions, severe asymmetries of shoulders are corrected with neck therapy. Vertical dimension is affected by head posture significantly. And also head postures can create anterior open bites. But the most important of all those, I really didn't put it, is that when the atlas, which is really what holds the head in place, there are asymmetries in the atlas. Those asymmetries will actually reflect in the height of the condyle. So if you have one side of the atlas higher than the other, well, that means one condyle on the right side or left side will be higher than the one on the other side, and that can significantly affect our how we design occlusion, of course. But we assume that the glenoid fossa is fixed and that, our condyles are perfectly, parallel and symmetrical. And that really isn't true most of the time. This is a quick one, and it's again about the position of the atlas. If you take a ruler and you go from the symphysis here to the angle of the mandible and you extend a line posteriorly, if that line is not about an inch inferior to the inferior border of the occipital bone, most likely there is distalization of the head in there, and that means that patient needs head therapy. Head and neck therapy through manual therapy. And you see this a lot on patients with temporomandibular disorders that are complex and associated with frozen shoulders and things like that. So it's just a random information, but it's just basically to show you how important is the neck. So I think that's the end of the presentation. Basically, in summary, I guess, in my opinion, occlusion is something that is complex, and we need to be a little more flexible in how we approach it. I want to leave you with this from a friend of mine that I think in a way relates to occlusion and how we have all been taught about occlusion and how and there is not much time for questioning, I guess. We have about 6 minutes.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator